Okay, welcome. All right, the last day. Okay, geriatric suicide is my topic, and the reason why I'm talking about it is because I'm a geriatric nurse practitioner. That's one of the things that I do. And someone asked me to write an article, and recently I had a family member who was geriatric who had committed suicide. So I thought it was a good topic for me to investigate and to talk about. I'm not going to show you the YouTube unless there's time, but there are a couple of really good ones that really are very moving. I believe that going through the literature review that there isn't a lot of information related to geriatric suicide, and so I wanted people to be aware, to learn about certain risk factors, and to learn how to assess your patients when you see them, and to consider to try to increase ways of the treatment to help decrease the incidence. This was a quote that I thought was interesting, that no one who has not been there can comprehend the suffering leading up to suicide, which I can't imagine how it would feel to feel like you want to commit suicide. And no one can really understand the suffering of those left behind in the wake of suicide. And one of the issues is elderly who commit suicide, the people that are left behind, they're high at risk of committing suicide also. Their spouses, partners, and often they're elderly too. Okay, so in the literature, they do say that the elderly are a special population of suicide victims. And geriatric, the amount of geriatrics in the world, the population is increasing, and as long as that's increasing, then the incidence of suicide in the population will be increasing. And they say that there were over 600 million geriatric people in 2011, and they say we're going to have over 1.2 billion in 2025. So. And the baby boomers are booming. So the elderly consist of approximately 16% of suicide incidents in the U.S. So we have the largest number of suicide of geriatric population that's known in the literature. And they say that approximately every hour and a half, a geriatric individual will commit suicide in this country. So that means there are 15 every day, and then there's over 5,000 every year. So those numbers are pretty high. So it's a major issue. They say that the rate of suicide in all ages is 1 to 12. In the geriatrics, it's 1 in every 4. That's a lot. So they have a higher average of actually succeeding, that about 25% of the geriatric population who actually succeed. So they're not fooling around, they're not calling you for help, they really, really mean it. Okay, so stigma is a really big thing, and we know for all ages it's a stigma, but I think for the geriatrics in the literature, it does prove that it's harder for them because their generation, they don't go to therapy as often as the younger generation goes to a therapy. They don't talk about being depressed, being unhappy as often as the younger people do. And so it's hard. So quite often the families will ask them to put accident or something for their etiology of why they died. So survivors have a really, really hard time. Like I said, they're at risk for suicide. So we have to really watch those individuals that are close to the people because they struggle with a lot of things. They feel guilty. And a really big problem is people will have a hard time getting support for themselves because of the stigma. And a lot of friends feel confused, or they feel they don't know how to handle, they don't know how to talk to the person, and so they have a hard time. And what happens is the survivors feel upset, so they kind of distance themselves for the people who would give them support, and then these people feel rejected, and so it's a vicious cycle. So then they don't really support each other. So it's hard. It really, really is for the victims, because it's more people are apt to talk to you if your loved one was killed by an accident or died of natural causes. But if someone's committed suicide, they don't know what to say. And often it's just to be there and say, "Can I do anything?" And you don't really have to say anything. Okay, so we talked about that. So risk factors. Risk factors. If somebody has a physical illness, that's a risk factor, and I'll talk about specific ones. If you have uncontrollable pain, or if you have a fear of a prolonged illness that put you at risk, your perception of your health is a big thing, because there are people that are they have a long list of illnesses, and they don't really feel that they're unhealthy. They feel that they're okay. They feel that they're going to make it. But there are other people that don't have a long list of illnesses who think, "Oh, I have cancer, I'm going to die, tomorrow." So their perception really makes a big, big difference. So just because somebody has a stage 4 terminal cancer doesn't mean that they think they're going to die right away. They may think they're going to live, and then they are going to live longer because of that, and they're not going to be at risk for committing suicide, at least not as high. Social isolation and loneliness is a big thing. And they've done studies now. If people had just one person to call them every week or to visit them every week, it keeps them alive, it keeps them going. And they've always said if you had one person in your life that you could go to, that you could reach out to, it could make a big difference. It's made a big difference for children growing up, and for the elderly, it makes a big, big difference. People that have major changes in their social roles, people who retire really are at risk, especially men, especially older white men. They tend to commit suicide more than anyone else. If they have a history of a mental illness, especially depression, PTSD, and again, I said if any family member has ever committed suicide. If people attempted it in the past, they have a really high risk too. So nurses are on the front line, so we see patients more than anybody, so we could assess and we could educate, and we could teach families how to keep an eye on patients, when to keep an eye on patients, and what to do. But screening is often overlooked because people feel uncomfortable asking people questions about suicide. But like someone said the other day, it isn't true. Asking somebody about suicide is not going to put the idea in their head. And some people do think about it. And let's see. So we have to at least know where there's counseling, know that there is medication available for depression and other psychiatric diseases, and it does help the elderly. Elderly aren't offered treatment as much as the other populations, but it does help them. Let's see, protective factors. If somebody belongs to a religious affiliation, they tend to be less apt to commit suicide. And if somebody has some responsibility to a family, or if they have children in the house, and if they have frequent contact with their spouse or their friends. Okay, so I worked for the VA, and there are a lot of elderly veterans out there, and they have a high risk of committing suicide. And a lot of it, they say, is because they were brought up in this military life, and they were told to suck it up, be tough, not to be afraid, and that, so it makes it difficult. It makes it difficult for them to reach out. And if they feel like they should self-sacrifice, then they're really at high risk. And if they feel like they're a burden, and for many people, if they have lost their sense of identity and they feel like they're a burden, they're at high risk. But the military, if they feel like they're fearless, it makes them more at risk. So they're a special population. Okay, so the barriers is, there are many barriers, but the number one, I think, is people are really, really reluctant to admit that they have suicidal thoughts. And we're reluctant to ask. And also, patients don't want to, and I don't think it's just the elderly. Patients, I think, want to give us positive answers. They want to give us the answers that they think we want to hear when we're assessing them. But we have to let them know that it's okay for them to be honest, to tell us what's really going on. And they don't always have to be okay. They don't have to be positive. They don't always have to be happy. Access to care for some is very hard, just getting there. And then coordinating the care. We talked about stigma a little bit. Okay, so it's a known fact that many people attempt suicide right after they're released from the hospital. And it may be a few days, it may be a month. But nothing's being done to catch these people. There's no special way of checking up on people. So something has to be done about that, because a lot of people are falling within the cracks. When it comes to visiting, if people aren't inpatient, if they're outpatient, people tend to commit suicide a week to 6 months after their last visit to, usually it's a primary care provider, and usually it's within 3 months. And most often, none of these patients will get mental health assessments or treatment at that last visit. So that means nobody asked them how they were feeling, what was going on, and maybe if they had, maybe they wouldn't have committed suicide. So it's, in my opinion, they really should be part of our routine to ask people, especially when they're older. But patients tend to feel more comfortable talking to their significant other about suicide than they do with their primary care providers. But I think it's we don't ask them either, and we kind of rush them in and rush them out. And it's difficult because of time, but it's important. So, okay, so there is a lack of knowledge. We talked about that. Okay, yeah, research tends to exclude a lot of elderly, which I thought was interesting. So we have to do a lot more research, and there's a lot being done in other areas, but not in this area. Okay, so we have to change our attitudes. We have to be more comfortable. We have to communicate more, and we have to know our resources. We have to know what's available for our patients out there. And we have to be able to assess for depression, which is a little bit difficult, and other mental illnesses. All these mental illnesses make them more at risk. But the elderly are a special population because sometimes they fall under the cracks. They may not be restless, they may not appear sad, and they may have what they call as subclinical signs and symptoms, so they may not fit into the category of the typical depressed patient. So they're a little bit harder to diagnose. But they say the depression diagnosis is increasing with geriatrics. And let's see, so we talked about that. And sometimes their medical illnesses will be the cause of them having positive signs of depression. Like they could have hypothyroidism, and they may feel tired, and they may feel sad, but it may be something physical. So we have to make sure that we assess that and make sure it's not that. And also, they have a lot of comorbidities. So it's kind of hard to figure out the signs and symptoms. Is it because of their disease? Or is it because of their medications? So we have to make sure that we screen their medications, make sure that we are sure that it's not the medications. If the patients are in pain, and then they tend to be more depressed, and it makes sense. So if we take care of the pain, their signs and symptoms of depression will be decreased. Losing control is a big thing for the elderly. I always tell my patients, give your patients choices, give them some control over their lives. Don't tell them that this is when we're going to do this. Say, would you like me to do it now or do it later? Because they lose a lot. They lose their driver's license. We just took my mother's away, and she's having a hard time. They lose some of their hearing, some of their vision. They lose their jobs. They lose income. They lose their homes. So it's a big. I mean, they have lots of reasons to be upset. Let's see. So they have to adjust. They have to adjust to moves, and so what we need to do is help them adjust. We can help them. We can help their families, and just like maybe if they're going to be moving into a nursing home, take them to visit. Maybe recommend that the families take them in a few times and show them around, and they don't just dump them off one day. Which happens a lot. And isolation, like I said, if people have social connections, they tend not to attempt suicide. So people have to, somehow we have to help them get to the organizations or have the organizations get to them. And so we have to know like what kind of vans are available, what kind of social services are available, because that could really make the big difference. Okay, so if people have certain diseases, they're at higher risk. So if they have lung or renal, then they tend to have higher risk of attempting suicide. And cancer patients, for the first year of their diagnosis, they're at risk. After that, it kind of dies down. If they're on dialysis, the first 3 months. And I could see that because it's, I would say dialysis is a job that you can never retire. And you can never go on vacation, and so it must be really, really hard. So the period of adjustment is very, very difficult. These diseases make people higher risk than others. Parkinson's disease, we know Robin Williams had that, and that made him depressed, and he committed suicide. If they have MS, respiratory diseases make it very difficult, and if their disease affects their body image, how they look, that's always very devastating. So that always makes them a higher risk. Okay, so they say that suicide ideation is very common in elderly. So only 6 to 20% of elderly that actually have suicide ideation actually attempt suicide. So, which I think is interesting. So they say that this might be a normal process of the aging, to think about suicide. So that's good that we know that now, or at least I found that in the literature, and it came up a few times. It's a way of people coming to terms with their life and their end of life, and then they're making choices. And sometimes they decide that they're not happy, they're not going to get any better, and so they do attempt suicide. So it is common for the elderly to think about suicide. It doesn't mean they're going to do it, but it's very, very common that they think about it. And they say it may be a normal process, so that's good. So that means they're probably going to be more apt to talk about it if they're all thinking about it. So, dementia. When people first find out that they have Alzheimer's or they're having some kind of brain changes, that's when they attempt suicide early on. Later on, of course, when they're advanced, they don't. But we have to let families know that when they're first diagnosed, that's when they're really at risk. And there are normal changes in the brain, but They don't really happen till later on, and they shouldn't make significant changes. Let's see, we have to look at people's cultural aspects. We have to look at how their culture looks at suicide. It might be accepted, it might not be. So that's important. Okay, we said that religion really is something that holds people up, and it protects them. Or even if they belong to a senior citizen group, that helps, as long as they have some social connection, as long as they feel like if they have support. Now, just because somebody has a family, just because somebody has a significant other, it doesn't mean they feel like they have support. And just because somebody has family that lives far away doesn't mean they don't feel like they have support. So their perception is what it's all about. Like I said, men tend to commit suicide more, especially older. And most of our supportive assistance is geared towards women. So we have to change that, because most of the men are the ones that are more isolated. They're the ones that are attempting and succeeding in suicide. So we have to change it. So we include them. Men, if they have visual, neurological, or they have malignant impairments, they're really at high risk of attempting and committing suicide. And if they have aches and pains, if they have chronic pain. So pain is a big thing. Men are more deliberate. The elderly are more deliberate. That's why there's more elderly actually succeed, because they're more deliberate about it. Okay, so it's harder to assess, like I said, because of time, comorbidities. They have such a long history. They have impaired communication sometimes. Sometimes they have a hard time with their hearing, with their vision. So it does take time, but it is worth it. And here's a list of medications that may also give you signs and symptoms of depression. So there's a lot of categories. So we have to make sure that we look through their meds and see do they really need these meds? Should we change them? Okay, so talked about that. Now the thing is, if we should screen our patients every time we see them. It should be part of a protocol to ask them if they're feeling down, ask them if they've ever thought of suicide, at least yearly, and then we'll know. And if somebody is at high risk, we have to keep an eye on them. And so there's a 2 question, and then if they're positive, then we go on to the 9 question, and that should be part of the routine. It should be in their records. And then people, we could send them notices. We could flag when they have special dates, like an anniversary of somebody who died, an anniversary of somebody who committed suicide. So we could contact them and make sure they're okay. And that has made a difference for a lot of people. And these are the questions that you would ask if they have a plan, of course. If they have a history of attempts, number of times, what they use, or if they've hurt themselves. It doesn't have to be a suicide attempt. Even the elderly do cut themselves. Elderly men do cut themselves. They do cut their veins in their arms. That is one of the ways. So if you notice any change in your patients, or if they change their medications, especially in the first 2 months of changing, if they've been on other antidepressants, and then all of a sudden they're on something new, even though they've been on antidepressants for a long time, if they do have a change, you have to keep an eye on them, at least for the first 2 months, a close eye, because that's the time when people commonly commit suicide. Okay, so what we recommend too is, if you know that your patient is suicidal, then you have them write a contract, and the contract is a piece of it's a document that says that if they feel suicidal, that they're going to get in touch with people, and they're going to write down who they're going to get in touch. and how they're related and their contact information. And it does seem to help people, and as long as they can get a hold of those people. And I do have a list of resources and places that people can call, they answer 24 hours a day. So if they can't get a hold of their personal people, they can call other people. And these resources are on this contract, and they have a couple of copies of the contract in their house. Okay. So there are different methods. These are the most common methods that the geriatric population will do. The jumping surprised me. I didn't think that would be on there. A lot of them keep their medications. They hoard their medications, and a lot of them have medications like narcotics, and they have pain medications, they have sleeping medications, they have sedatives, and they often use that. So if we could call our patients more, if we could text them, email them, mail them, keep in contact with them more often. A lot of the elderly miss appointments. They're saying that the older, 85 and plus, they miss 20 to 25% of their appointments. And there really isn't a lot of follow-up in the system. So we have to follow up and check up on these patients. And they're very vulnerable, and they're at risk. So we have to know the dates. They're important dates of the special anniversaries, and make sure that somebody gets a hold of them. Just make sure that we flag them, we talk to them. And in studies, a few studies, if people were given case managers, and these would be the people that would contact them and send them things and call them, they had fewer signs and symptoms of depression. And I know one of the clinics where I teach the students, they have case managers, and it's wonderful. And it's the same person that'll contact them and email them and call them. And it makes them feel like somebody cares about me. Somebody noticed I didn't show up. All right. Resilience, is my time running out, or did it run out? Oh, okay, all right, so then I guess I'll have to stop. Does anybody have any questions? Okay, all right, thank you.